and Senate buildings once you got through security. But anyway, I'll try to keep you entertained. There should be plenty of time for questions at the end. I think you could either raise your hand or wave or type something in the chat. But I'm basically going to go over a little bit about our structure and then get into some of the key federal and state issues we're working on. This is going to be somewhat repetitive next month, but I'm going to structure it a little bit differently. But when I do a overview for the residents in your training session in the afternoon, I like to go over a little bit about who the key players are. So hopefully that'll make sense. And if you have any questions, as I said, I'll be happy to elaborate on that. We've had a program of congressional liaisons, which are pediatric dentists. And they essentially go to Washington, D.C. periodically to talk about our issues and to build relationships and work with our folks in D.C. who are at our lobbying firm we engage. And actually, there's a recent transition. You'll hear more about this in D.C., but these are two former presidents of AAPD who just were appointed the year before last to do this. They were all excited to make frequent trips to DC, and then COVID hit. And finally, we were able to go with them in November this past year and to see some people in person, which was great. But Dr. Bro with the bow tie is from the practice in Baltimore, Maryland, and Dr. Jade Miller is practices in Reno, Nevada. So we have sort of a geographic spread, and they will be with us in DC next month as well. We have a Council on Government Affairs, and I'm not going to go through all the members. All of our councils and a lot of our committees will have representatives from each of the 5 AAPD districts. And I'm not going to quiz you on that, but they're all broken up geographically. As you might expect, California is in the Western District. But our chair is Dr. Jessica Robinson in Flagstaff, Arizona, who is a UCLA pedo grad, by the way. Dr. Angel Stout, or Angel from Bethlehem, Pennsylvania, is our board liaison, and I serve as staff liaison. So what do? Well, they're the ones that recommend, review, and establish priorities subject to our board's approval and try to position us to be effective on these issues at the national level with the United States Congress. They also try to provide support to our chapters through our public policy efforts, which I'll mention later, and try to work with other agencies and associations. And while I don't have a slide on this, I do want to point out we do work very closely with American Dental Association on policy issues. And also we work with some groups outside of dentistry like American Academy of Pediatrics. There are a number of coalitions at the national level we're involved in. So it is, in some cases, as you'll see, we're part of much larger groups of coalitions of groups advocating. Other cases, we may be the lead group, and there might not be that many others involved. So that sort of depends on the issue, if you will, and you'll see this as I go through. Now, underneath government affairs, we have the committee, Medicaid and CHIP Advisory Committee. Medicaid and CHIP being very large public insurance programs, pretty important on children's oral health, particularly because children's oral health is a mandatory service under Medicaid. So this committee is composed of folks who are very interested in participate and try to help us navigate. And Scott Cashin is actually he's a vice president now. He will be president in 2 years, and he's from North Carolina, actually Greensboro, but he just sold his practice and is going to be full-time faculty at UNC Chapel Hill Pediatric Dentistry Department. And Dr. Marilia Montero Fayad is our board liaison. She actually practices in Chicago, right next door to our building, the American Dental Association headquarters, where we are located. And Robin, who you'll hear from next week, is our staff liaison. Naturally, I'm home by myself, and somebody's walked by the front door, so my dogs are going crazy. So Hopefully
Yeah,
that's-
just to confirm, that's not me making that noise.
Okay.
We're,
All right,
we're,
hold on one
we're,
second here.
we're all dog lovers here, so don't mind. We love
Oh,
dog.
It
Yeah,
is
that
close
was
to
the,
yeah.
You can bring them to
that
us
was the
if
reason
you like.
my slow delay on was because I was taking care of my dogs too. So I feel you.
Yeah, well, the thing is, I was telling Dr. Ramos Gomez that my wife is in Laguna visiting my older daughter, who's in art school there. And my younger daughter just flew out to visit her boyfriend in the Washington, D.C. suburbs. So I'm here with the dogs. So I try to keep them entertained, but they can't. When somebody walks down the sidewalk, that they take that as a personal affront. That must be barked at. Anyway, moving right along. So this group, the Medicaid committee, works in helping us liaison with the various officials. And Medicaid being a federal state program, there's officials at the federal level plus state agencies. They try to monitor and keep our leadership informed. They want to work on increased access. And there's an annual meeting of Medicaid CHIP dental directors that they participate in each year. And then you probably figure out there, besides public insurance programs, there's private insurance programs, which are a big deal and important, and sometimes they can be frustrating. And we try to help our members navigate them and work to reform those programs as well. Although obviously with private insurance, it's not always able to change a law. They are regulated by state and federal governments, but it's often a dialogue with them. And sometimes it's advocating directly with payers to say, hey, this dental code should be covered by your program, or you should allow more frequent visits for children who have certain conditions that need to be seen more frequently than twice a year. So our chair is Dr. James Nickman, who is also a past AAPD president. He's from Minnesota, St. Paul, Minneapolis. Dr. Fayette already mentioned earlier as our board liaison, and our staff person just retired at the end of the year. So we are looking to fill that, but actually Dr. Nickman's going to be doing some additional consulting to help our members out in 2022 as issues come up. And speaking of those issues, it's helping our members when they have questions on insurance as well as coding. And a lot of the coding is an annual review where you can propose new codes, modify, delete them. There's a whole process. And actually, Dr. Dickman's our representative on the Code Maintenance Committee of the ADA. So that's an annual process, and any member can submit a code, any organization can, but that's an important aspect as well as affecting every day-to-day practice. And also, again, often sometimes we're promoting coverage for services. For example, there are case management codes that are developed a few years ago. Not every program, public or private, covers them. So we promote things like that. And you'll hear a lot more about general anesthesia issues, both today and also in DC next month. And then we have our Oral Health Research and Policy Center, which with our Dr. Casamasimo is a retired but very busy, still doing clinical work at Children's Hospital, Nationwide Children's Hospital in Columbus, Ohio. Does consulting with state Medicaid, but he's our chief policy officer. You met Robin, you'll hear more from her next week. We just hired Rachel as our research project manager. That means she's doing a lot of staffing for evidence-based dentistry, development of clinical practice guidelines, which is a whole other area that's very important. And those are the folks who go through tons of research studies, clinical studies, and try to pull from them, what does that mean for practice? And Claire's our project coordinator. And again, Isabel, you met earlier or on the screen. This is a program we established now a couple of years ago at University of Chicago, where a recent grad gets to spend an entire year with us, which and actually, fortunately, since last summer, we've pretty much been in the office 4 days a week. So it's been at least she's had FaceTime experience. It was sort of tough during the first part of COVID, where when you bring in a new person, you don't see them other than on the Zoom. But fortunately, that's been changing. So one of the reasons this center was created about a decade ago was to help analyze data and conduct research to help get into issues, probe issues that are important, and have resources to support our advocacy efforts. And the reason that's important is so much when you're arguing for a certain policy, the first thing people often ask is, what's the data? Why is this a problem? What's going on? Why would what you're proposing solve it? So we felt this is a way to have intellectual backbone and do things that are focused on pediatric oral health and selectively pick projects that are important. And I think you'll see from a couple of these, which you can read these all on the website. But in 2021, they were pretty busy. This one was technical brief, we call them, and there's a series of them. This is talking about restorative choices, and particularly pointing out the importance of stainless steel crowns for children. And it becomes an issue where sometimes the insurers will say, well, they're a little bit more expensive, so why don't we cover something less expensive? And we're trying to point out, well, but if you're covering something less expensive that isn't as durable and you're replacing it 2 or 3 more times, why wouldn't you just get something that's going to last until the primary teeth falls out? And that's probably the end of my clinical analysis there, as I'm not a pediatric dentist. But again, this was an important issue that came up a lot with private payers and Medicaid. And then there's a report just about what's the importance and uses of silver diamine fluoride. It's not a panacea, but it's an important tool in the arsenal. It's definitely changing the way things are practiced. But the Academy wanted to give our review on what you can do with it, and what some of the limitations are and so forth. So that's another one out there. You can read at your convenience. And then we talked about this right before we started. Often we were trying to petition private insurance or public insurance, Medicaid, to say there's a code here that's important. Your program doesn't cover this procedure. You really should. So we've done this report now for the 2nd edition, Central Benefits. And then there are 2 reports related to operating room access, which has been a critical issue, particularly the last couple of years, sort of a growing issue that got worse because of COVID. But the first one is essentially documenting the extent of the problem, why our members are losing a lot of time and they used to have to do cases in hospitals and ambulatory surgery centers. It is worse in some parts of the country than others, but we've been trying to track that. So this is a nice overview. The second one is more of an insider game, not so much for public policy for legislators, but for our members to look at some options they may want to consider, either trying to partner with, maybe even investing in or co-owning an ambulatory surgery center to handle some of the cases that in the past might have gone to a hospital outpatient department. So those are both useful resources. Now, moving right along here on the people we work with, we don't have an office in Washington, D.C. The American Dental Association does. They have at least 20 plus staff there, in addition to their headquarters in Chicago. But we did feel it was important to have people who really know how things work in the Capitol and working with Congress to help us out. So we've worked with this law firm since 2003. They are a big law firm, multinational, global, but they have had lobbying DC practice for many years. And so our current staff actually is fairly new. One of the gentlemen we work with is retiring. You're going to meet them all. They'll all be in DC doing presentations and other things. But it's actually a nice balance because Anna, without doing a sneak preview of their bios, Anna's worked on a lot of different associations in terms of lobbying health-related issues. And before joining Hogan Lovells, and back in the Clinton administration, she was involved in domestic health policy in the White House. And so she's Democrat. Colo worked for Senate Appropriations and for a Republican senator, and got his law degree while working on the Hill. So it's a nice party balance there. Just we're very bipartisan in our approach on our issues. And again, you'll hear from them in DC. And also in the last couple of years, because of the OR access, operating room access, we engaged a firm that does a lot of work with the Centers for Medicare and Medicaid Services, or CMS. I want to talk about this in more detail in DC, It's a bit technical above this HCPCS and what that all means. But essentially, because we don't have a specific code for dental cases, the facility fees that a hospital or an ambulatory surgery center get are ridiculously low. It's a real disincentive for them to ever to schedule a dental case. So we're trying to work on that, and we've been working with Julie Allen and Diane Millman on that. And Julie will actually be in DC and helping me with the briefing. Now, a lot of issues happen at the state level, as you're probably aware. Licensings are granted by the state. Medicaid, a lot of Medicaid is run by state decisions with the federal oversight and guidance, and a lot of local issues. A lot of issues may be better addressed at the state level. So we have chapters, California Society of Pediatric Dentistry being one of them, in just about every state. There may be one or two that aren't very active, but for the most part, we have it. And we decided, the leadership of the Academy decided back in 2012 that it would be nice to have a point person for each chapter. That would be a multi-year appointment to help coordinate their legislative issues, get resources from AAPD, communicate with us. So we set that up. We have Zooms with them quarterly. We send a lot of emails. We have conferences. All of them were invited to come to DC, and most are able to. And I think we have about every state covered, except for poor Wyoming, sorry. California, by the way, was the model for this, because going back to the 1990s and early 2000s, Dr. Paul Rijardo, who is now the executive director of the CSPD, was the public policy advocate. He did such a great job of coordinating and covering dental issues with in Sacramento and dental board issues and so forth, that it's become the model that now we use in all our chapters, which has been very helpful to keep track of it. And certainly for the Academy, we can't necessarily be on top of every issue in all 50 states plus DC. This helps us do that and communicate and coordinate and share information as well. And again, you'll meet a lot of those people in DC. I encourage you to chat with them, get to know them, particularly the folks from your state. Dr. Natalie Mansour is the California PPA now. Now, I know she's a big USC Trojan fan, so you guys are going to have to reach some detente or what have on that point. But nevertheless, their role essentially is to help represent the State Pediatric Dentistry Association with issues at the state legislature, again, Medicaid agencies, the licensing boards, work with coalitions. That's another big one. There's most states now have an oral health coalition, which are not just dentists, they're public patient advocates and so forth. And that's often an important voice to show that it's an issue that's going to help patients, not just the providers need this and so forth. So this has become very important. And also to work closely with the State Dental Association, because most state dental associations have full-time lobbyists, government affairs staff, or hired lobbyists, and have resources and know the legislature. So we certainly try to coordinate that with them. So again, you'll meet a lot of those PPAs, as we call them.
Scott,
So,
if I can ask you, can you go
you
back?
may, yes.
For our future public policy advocates in California, which might be here from UCLA, what do they need to do to nominate themselves, or how can they reach the point to be considered as a public policy advocate?
Yeah, well, we'll have a slide in VC that any of you may become a grassroots advocate, which simply means that we have a grassroots alert, you'll get the email and so forth. The PPA program is just one person who's nominated by the state chapter, and it goes through our Council on Government Affairs for review. So while that's obviously limited to one, it doesn't mean they can't have a committee on government affairs, as a lot of our chapters do, or even, we've told them, hey, you want to have an assistant PPA or whatever to help you out. I think one of the things I suggest is talk to your PPA. If you say, hey, I'm interested in doing this, how can I help? I'm sure they can find some project you can work with on. So again, while we like to have the one point of contact, we did not intend this to be that person gets every project, dumped on them and nobody else helps out. I think they would appreciate the assistance. So, and I'll remind you all about this too at the residence session and on Sunday afternoon in DC, that's good way to get involved, and also getting involved at state level, because there's so many important issues, that are addressed at the state level as well as national. So
Absolutely. Thank you.
thank you for the reminder. And just the last thing is without getting into all the campaign finance and all issues about whether are super PACs good or bad, and independent expenditures. You could have a whole lecture about federal campaign law and the Federal Election Commission. But the bottom line is a lot of groups who are active in advocacy will have a political action committee. This is for congressional support. And we have a steering committee. And we have representatives from the various districts. Kyle House in Oregon is the Western district. So basically, it's a nice, pretty geographic spread. Dr. Hardman's in Milwaukee, Dr. Fujimoto's in Hawaii. APD staff, Dr. Rakels is our CEO. He and I serve as, he's treasurer and I'm secretary. Carrie Dobbs in, I believe, Durham, North Carolina. No, she's North Carolina. I think it's Durham. And Angel, I mentioned earlier. Then Bob Moreau's Massachusetts. Chad Essinger's Tennessee. Colleen Green's Milwaukee, Children's Hospital Milwaukee. And Jason's in the Dallas, Texas area. So they're going to meet next month. And what do they do besides they try to raise money for the PAC, and then they try to, let me see. Oh yeah, sorry. They support candidates who advance the oral health needs of children, et cetera. So we're trying to find folks who can help us out, who've helped us and are in positions to help out. And it is an important part of what goes on in DC. And I will tell you every day, particularly in an election year, I get emails, multiple emails, maybe 10 or 15 a day for different events to raise money for candidates in both parties. And they're starting to become in person now. For a year or so, they were Zoom because of COVID, but that's a constant thing. And the way our system is now is that they have to constantly raise money if they're going to be successful in elections. That's just, to buy TV ads and all that is very expensive. Of course, more expensive in bigger states like California and bigger markets. There happen to be 5 dentists in Congress now, just FYI. Drew Ferguson from, and I always, well, let's say I'm going from the guy on my underneath the logo. So Drew Ferguson from Georgia, Paul Goes, Arizona, Mike Simpson from Idaho, Brian Babin from Texas, and Jeff Andrew from New Jersey. So that's the most dentists there's ever been in Congress. So that's a nice thing to have. There's probably about, 25 or 30 or more physicians of various types. And it's good to have healthcare expertise, but needless to say, a lot of the physician groups go to them on their issues. So the dental folks tend to understand our issues better and can be a big champion for them. So that's important to know. I think Dr. Van Drew is the snazziest dresser of them. So anyway, we did host a fundraiser for him when we were in DC last in 2020 for this conference. And then in 2021, this conference was virtual. So we missed a year, but we're, again, normally we've had a fundraiser for a member of Congress. This year we decided that we need to raise money for the PAC. So we're not going to have a candidate. We're actually just going to encourage voluntary contributions to support our PAC so we can build up our coffers and be able to have money just to give out between now and the election. And we've already given out a certain amount, but we have a lot more that we've committed to between now and November. And again, as you'll be reminded, the congressional election cycle is every 2 years. Every member of Congress and the House is up 2 years. The Senate, it is a 6-year term, which means a third of them are up for re-election every 2 years. Up for re-election 2 years. You can look at our annual report online for more information, photos, and who our contributors are from APD membership and candidates we supported. And I do want to say again, it is very bipartisan. You'll see members of both parties. Probably tilts a little bit more to whatever party is in charge of and has the majority, which means they have the committee chairs. So I encourage you to look at that at your convenience. And a lot of the nice things about what a PAC can do, I think we're very positive, is setting up time to meet with and participate in events and have people come to your office. So we have Congressman Dennis Babin meeting with our Dr. Zimmerman and locally, and Dr. Reyes, a former PAC chair of ours, meeting with Congresswoman Yvette Clark in Brooklyn, New York at her office. She's been a real supporter on several key issues. And the bottom one is Senator Tammy Baldwin from Wisconsin, couple years ago, meeting with a house of one of our members in Wisconsin. So it's nice to be able to do some things like that. And frankly, you have a little bit more time to converse with them than you will in a typical meeting in their office in DC. And again, there's a few more. I think Senator Fisher from Nebraska is in a pediatric dental office of Dr. Miski and Randall in Hastings, Nebraska. Former President Dr. Joe Castellano from Laredo, Texas is there with Congressman Henry Cuellar. And I think the last one is Congressman Womack in Arkansas of Dr. Sisla. But again, these are great opportunities, and we work closely with our members in programs in terms of looking at events locally as well as events in DC. So I think overall it's very positive for trying to build relationships with members of Congress, and you'll hear more about that certainly when we are in DC. So with that, I know it's a long setup, but I'm going to run through some of the key priorities, and then I think we'll have I'll open it up and see if you have any questions. But you can look at the entire list on our website that's developed each year, recently approved by our Board of Trustees. Our Council on Government Affairs goes through reviews, see what we've accomplished, what can come off the list, what stays on it. And we follow this because really you have to set priorities so that you're not running off on every issue under the sun and sort of dispersing your effectiveness. We do note on some of the issues, we are the lead group, and if frankly, if we weren't taking the lead, it probably wouldn't move forward. Where there are other issues where we may be very supportive, but it's a much larger coalition, and we are not the only voice advocating for it. And that's something to be taken into account as well, because if another group's taking the lead, we're happy to support that. And sometimes it's the American Dental Association. It really depends on the issue. But as you'll hear when you're in DC, the main thing is that whenever you go to do a successful visit, state or local, state or federal, or you really have to prioritize and come in with maybe no more than probably 2 or 3 requests. Doesn't mean you don't support 25 things, but you're not going to be very effective if you go on and say, here's our list of 25 things we want changed in federal or state law. So one of the issues we'll be talking about is Title VII, HRSA Title VII funding, and the importance, and the dental faculty loan repayment program, and continued preferences for pediatric dental faculty. I'm not going to get into too much of the strategy because I'm going to go over this in our briefing for DC. But one of the nice things, particularly for UCLA, is to talk about successes from Title VII funding. And you happen to have a program that's been very successful over a number of years and can give some examples. And a lot of this politics is being local. It's nice to know that nationally this many grants are supported, but the member of Congress, particularly the House member, wants to know, well, how much has this impacted my district and my area, my constituents? And you can say, hey, this made a big impact for this reason and that. That's stuff they want to hear. So you all have some great stories, and I have a lot of information. We have a lot of information for other states to share. Not every state is not applicable to every group, but a lot of the states have had grants. So we like them to focus on telling that story. And in fact, we also update our profiles of faculty loan repayment folks, which we're going to do. So some of the people going have been beneficiaries of that. We're also working to try to make that the recipients not have to pay taxes on the repayment. Because unless you have a specific provision in the Internal Revenue Code, if you ever get a loan forgiven that doesn't have a provision, like the National Health Service Corps, for example, has a provision that's not taxable income. But if you don't have that in the tax code, then the IRS considers that to be taxable income. So we'd like to make the program more effective by fixing that. So that's Title VII. Again, you're very fortunate that you have so many great Title VII stories from California that I don't really have to coach y'all too much on that at all. There are some issues with student loan reform, and you may, if you read the ADA Morning Huddle, I believe they had some blurb about this today, but there's this READY Act. And you probably figured out already that having an acronym for your bill is always clever and easy to remember. That was introduced last year by Congressman Babin, the dentist, and a Congresswoman Houlihan from Pennsylvania. It actually was just introduced in the Senate on Wednesday, And we were mentioned in the press release, ADA and others. And again, we are a member of a larger coalition on this. AMOS's oral surgeons have been particularly engaged. But this essentially would halt your interest accrual while your loans are in deferment during residency. So it would definitely reduce your cost of paying back student loans. And there's also another one, which I don't know if it's ELSA, maybe that's Ensuring Lasting Smiles Act, or ELSA, is one we've supported over the last Congress. I think it goes back at least one Congress, to require health plans to cover these medically necessary treatments of patients with congenital anomalies, and including the related dental procedures. Has a lot of co-sponsors in the Senate and House. I'm going to go over some of the strategies and how to get this over the finish line and some of the challenges. But it's definitely been a coalition effort. And besides the oral surgeons, one of the patient groups that's been really big on this, and they have a whole section on their website, is the National Foundation for Ectodermal Dysplasia. And obviously they're folks with that, kids with that condition. This is types of surgery they need to be, better functioning in oral health and overall health, of course. So that's one we'd love to try to get that through, particularly since it has a lot of overwhelming bipartisan support. And I mentioned this earlier, and I'm going to talk about it more in DC. And you don't have to memorize all these. We're trying to get a code in HCPCS level 2 category G, which honestly, until a year and a half ago, I didn't know what the heck that meant. But we are working again so that the facility fees for dental cases can be competitive and we don't lose operating room access. We are working, besides with the outside consulting firm, we were working very closely with ADA and AMOS. Actually, all three of us are supporting the work of that firm, and Julie Allen in particular. And recently, we got some bump, with fortunately working from the American Academy of Pediatrics. They weighed in a letter of support, which to the agency. So again, you'll hear more from that from me in DC. A lot of Medicaid issues, both at the federal and state level. I'm not going to go all the stats about how many people are covered, how many children are covered, but it's growing in percentage. It's a pretty significant program in terms of children getting dental insurance. Now, there's a whole history of whether it's working as effectively as it should, and it varies a lot by state. And I don't have time to get into all the ups and downs about some states that have made progress, some have dropped off, some have been increasing. South Dakota just had a bill that went through increasing fees and for some services. But there's a few basic things we focused on. At the federal level, we certainly support efforts to make adult coverage mandatory, which there's a bill now that Senator Cardin, Maryland, has. And I think that's because it's better for the parents to have coverage and more prioritize it for their kids. Because one of the challenges of Medicaid is you have the coverage, but do you seek the care? So it's the difference between coverage versus utilization. Has always been looked at it as the utilization. Can you push it closer to what the utilization is for private insurance? And of course, both of them, you hope the utilization will be better and they would establish dental home and not wait for episodic care or go to the emergency room. So that's a whole thing that's been a big deal in dentistry for a number of years. We want to make sure there's fair audits and peer review by pediatric dentists and appropriate training. And we want to make sure there's appropriate and better oversight of managed care contracting, which has become a big deal in many states, and especially on the network adequacy. And I'm not going to, again, all of these, we can go into much greater detail, but these are ones that are important. In fact, right now, there's an ADA Medicaid task force that they created, which has several pediatric dentists on it. I'm technically a consultant, and they just started meeting. So I think they're going to come up with a number of reform suggestions for both federal and state level, which I think will probably track pretty closely what AAPD's priorities are. Now, I'm turning to state issues because, as I mentioned, Medicaid is a federal-state partnership. So hence, some of the reforms that we'd like to see it have to happen at the state level. So that's why we provide technical assistance for our state chapters, our public policy advocates. One of the big things that the states decide is the fee schedules, reimbursement. That's not a federal decision. We've also worked to promote the adoption of our dental periodicity schedule, which is actually dental periodicity is required under federal law, we found not all state programs were adopting it. More have done so now. We have a whole section on our website about that with a nice map and everything. So that's it. And then I think this is getting back to kind of tracking and see how managed care programs are effective, and make sure that we can still have accountable fee for service as needed, and that the managed care programs do not wind up just collecting premiums without adequately covering and reimbursing for services. There is a guide that the ADA's put out on about 5 years ago on developing contracts, the RFP, that state Medicaid agency managed care organization. And that's become a big issue now, about trying to make sure that the contract that state Medicaid agency has with a managed care company is effective and has adequate network and so forth. We're going to have probably more presentations about this for many AAPD meetings for many years to come. I know we're going to do one in the fall for our PPAs, because this Medicaid managed care contracting is really a pretty huge issue in the program at least. And continuing here, also at the state level, since the state level, a lot of audits are carried out by staff from the state Medicaid agency. We want to make sure it adheres to our clinical guidelines. And in fact, we would like it that if the state Medicaid manuals actually reference our guidelines in terms of the appropriate criteria. And we also like to see the dental advisory board for every state Medicaid agency. So again, these are a lot of things to work on, but that's one of the reasons we have the state PPA program and to try to achieve success. And some states have done better than others and on this, but it's a pretty big issue, as I said. Oh, and then going to third party issues, there is a model contracting bill that was adopted by the National Council of Insurance Legislators, which is basically legislators who focus on health insurance related issues. And that's actually been adopted in a number of states. We support it. It's been a big issue for ADA. And these are the three things that we focus on in terms of helping to improve the benefits contracting. And again, prior authorization in terms of if they authorize it, they dental insurers should pay for what was authorized. And the network contracting. So that's an effort to try to have a model regulatory reform for private insurance, which is also important. So again, I think you got the sense there's the public insurance and Medicaid, CHIP and all that. And then there's also private insurance, and both of them have issues that we want to work on, improve and track. And sometimes there's progress and sometimes there's issues and challenges. And just real quickly on the audit, one of the reasons the audit issue became so big was because in one state a few years back in Nebraska, 3 or 4 years ago, they basically called into question all of these operating room cases where there were stainless steel crowns, saying you should have placed something less expensive. So again, that consistency of our guidelines and the appropriate peer review are pretty important principles. Now, the good news is, because that Medicaid actually has a chief dental officer in CMS in Washington, D.C., who's a pediatric dentist, Dr. Natalia Chalmers, and she's going to be speaking at our conference on Sunday. So that definitely helps a great deal in terms of making sure somebody within the agency, when they're having meetings behind closed doors that we can't have access to, that they understand the oral health issues. A couple issues with dental boards that have been big in recent years is one is if they're looking at regulations on sedation, we try to point them in the direction of a joint guideline we have with the American Academy of Pediatrics. And also, we want to make sure that they are adequately monitoring advertising in terms of making sure that consumers understand who is a specialist versus who may be a general dentist who we welcome as affiliate members, but don't want them to say I'm a pediatric dentist or imply that they are. So that's a balance there that we think states should be protective of the public to make sure they, it's clear in advertisements on websites and other places about that issue. So that's quite a lot there. And again, I want to point out for wrapping up on the state issue that the state chapters definitely have to work closely with state dental associations, but also they can prioritize what they want. So when I have that whole list of state things, there's more on our list. It doesn't mean we expect them to go full steam ahead on all 10 items. They may decide this year the biggest effort is something else. I didn't even mention school entrance screening or assessments, which they have a law in California. Only about 14 states have that. So a state chapter may say that's going to be our big thing this year. So we give them the leeway there to make that determination. We are also, AAPD is not hiring their state lobbyists and running to state legislatures. That's something they're doing. We do provide technical support. We are working to inform them about how they might go through an RFP processes. A few more now have hired lobbyists at the state level. But again, this is something that they have to do with our support to be effective. It's an ongoing process, and I think there have been some nice successes recently in some states. I think the one that comes to mind is over the last year there were Medicaid fee increases in 3 states that hadn't had them in a number of years: Mississippi, Wisconsin, and Minnesota. So with that, I'm going to stop and take questions, make sure if hopefully I didn't confuse you too much of that. Again, some of these things will be reemphasized and gone over in DC next month. And I think you'll have a really good experience there as well, as plus networking with all of our folks. It's a really fun conference, and it's a great opportunity to advocate for children, certainly at the national level. So.
Well, thank you, Scott. This has been an incredible summary and review of some very, very complex issues that it'll be very nice for our residents to have a grasp in some details. So one of the things that you brought up that I want to make sure that they're all aware of is how to really follow the dots, right? I mean, you mentioned the examples of the stainless steel crowns and the questioning of reimbursement, especially now with all this huge debate on the whole technique and how just placing them out without any preparation and a stitch or anything, that would really have a huge impact in how they're going to be the reimbursement in the future. So the connection between evidence-based with the clinical and the scientific affairs committee of AAPD that relates to benefits, it's such an essential piece to bring to their attention, right? Have all these pieces that we tease them out, they have to be integrated in some form, shape, or way. The other example that you brought up was this impact on the hospital cases and how reimbursement is affected by not being able to get the appropriate timing for the full mouth rehabs under general anesthesia, and how this advocacy is going to help to ensure that we get appropriate space, time, and effort within the hospital. So that's another huge issue that I need them to be aware of and realize how this advocacy really will help to enhance that piece. Another one is the loan repayment, which is very dear to their hearts. They're all affected humongously by financial loan repayments, and see how this taxation issue is detrimental for them to be incentivized to do either faculty appointments or work at FQHCs or anything like that. So that's a huge thing that affects them dearly. And lastly, you know, this issue with Medicaid auditors and the use and really support of Medicaid providers. There are so much need, especially pediatric dentists and Medicaid providers, and how by adding the expertise of the Governance Council, the Medicaid Chip Council that we are part of, and the committee that you chair, we're able to ensure appropriate audits, right? With the other peers, other pediatric dentists doing the audits, and not just, you know, anyone coming out from high school or whatever that is, without the expertise of dental appropriateness, that they can review this case appropriately. So these are just some huge and very important examples that I want them to be aware of about how relevant it is in this era of training pediatric dental residents, that they should be these great advocates in the future for some of these issues that will affect them for the next 30, 40 years of their practice, right? So that's in a summary. So I really would like them to ask you any question. I'm sure that they're all very intrigued by several things. So I know Vishnu or Tarek, you guys have raised your hand. Is that right?
Whatever you want to, yeah, you raise your hand or type in a comment, whatever it's easier.
Oh, that was a wonderful, very informative presentation. Thank you. And I didn't raise my hand, but you answered a
That's
lot of
fine.
things.
As long as you can keep Zoom on to one screen, it's kind of for your sanity. I know we've all been in those where like 50 some people and you're like, I don't know everybody's. I can see all of you, so that's good.
That makes it easier way. I guess I'm curious. So because of kind of my previous experience and stuff like that, really talking about the repayment for OR time and stuff like it resonated really well. I'd love to hear. I know you're getting into like the nitty gritty a little bit on it, but just kind of what the rate differences like currently are and what we're hoping to move those to, because it's huge to be able to just have that access. It's just huge.
Right. It is. It's a little complex because you got sort of three things in play. One, let's assume the dental services themselves are covered by Medicare or private. But the bigger issue has been the hospital or OR facility charges, and then to some extent too, what the anesthesiologist gets reimbursed. Now, I'm putting that issue aside because usually what a provider gets reimbursed under Medicaid is a state decision. But what we looked into with the help of an outside consulting firm was, well, why was there such a disincentive for dental cases? And this was going on before COVID. And in fact, a decade ago, we tried to get a CPT code for the dental case. They said, no, you can't, it's not, no physicians are doing this, so it doesn't work. Anyway, it turned out that there's this code set, HCPCS, which honestly, I'm late Friday, I'm forgetting what it stands for. Healthcare something, but we'll go over this more, but again,
I used to have all this stuff memorized too.
there's a whole website.
Yeah.
The nice thing is if you go to CMS and you click on type in that, they'll tell you everything about it, what's in the HCPCS code. And the thing is, the dental code, this unspecified code, so I think it's 41899 that you would be using. And because of the way it's set up, and it's also weird, it's a Medicare code, but a lot of state Medicaid agencies use the Medicare code set, which also makes it. So when you use the unspecified code, basically, according to the analysis that our outside firm looked into, our consultant, say, well, a lot of cases which should be facility fees should be like $1,200 or $1,500. It's like $200, and in some cases it's less than $100. So that's what having the lack of a specific code for dental services is impact. It just makes it a disincentive. Now, it doesn't mean the hospital's gonna be forced to do this or that. It's just gonna put it at a more competitive level, if you will, with other cases.
Yeah, I mean, it's a thing that the administration of a hospital has to still look at the finances of their place. And if it's like, well, we're not getting reimbursed at a level, I mean, it makes sense that we have to make decisions for them. And if we can make it easier for them to be like, we want to prioritize children, we don't have to worry about the finance difference.
Right.
It makes a good argument.
Yeah, of course, again, there are other factors that certainly, one of the reasons we've looked into ambulatory surgery center options is because the types of cases they're doing are not are very comparable to some of the dental. It's not like you're kicking out a kids on open heart surgery or something like that. And the other thing too is certainly the relationships and the rapport is important as well. So we would point out, like, yeah, we want to help people have this be more competitive for hospitals financially, but there are also things we've tried to do. And that technical brief that Dr. Kessler-Seymour in particular was a key author, gets into some of the qualitative relationship stuff that also helps in terms of making, serving on hospital sets, making the hospital feel the pediatric dentist are part of the whole team, not just eventually, coming in every once in a while and making this. So there are other factors, but we think this will have a big impact. I'll tell you right now, and